Okay. Good evening and welcome. Thank you so much for joining us tonight for the webinar Obsessive Compulsive Disorder 101, presented by Dr. Robert Zambrano. My name is Katie Delaney. I am the Family and Medical Outreach Coordinator at the New Jersey Center for Tourette Syndrome, NJCTS for short. I will be your facilitator for this evening. Now, before I introduce Dr. Zambrano, here are a couple of housekeeping notes. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. If you have questions after tonight's session, you can post your questions on the Wednesday webinar blog, which is accessed from our homepage at www.njcts.org under the heading Programs. This blog will be monitored for the next 7 days. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendations or opinions made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now, it is my pleasure to introduce our speaker for the evening, Dr. Robert Zambrano. Dr. Zambrano is the clinical director at Stress and Anxiety, located in East Brunswick, New Jersey. Previously, he was part of the Rutgers Psychological Clinic's staff for their Tourette Syndrome program. Dr. Zambrano specializes in working with children and adults with OCD, depression, and other anxiety disorders, as well as Tourette Syndrome. He has been certified by the Behavioral Therapy Training Institute, which is provided by the International OCD Foundation. We are so happy to have you here tonight, Dr. Zambrano. The floor is all yours.
Thank you very much, Katie, and thanks everybody for being here. Just give me a second. I'm going to switch over, and hopefully we can all see my screen. And let's see, hit slideshow, and we should be full screen loading. So everybody can see, Katie, we can see OCD 101?
Yep, you're all good.
Thank you very much. Okay, so like Katie mentioned, I'm the Clinical Director of Stress and Anxiety Services of New Jersey. We have 2 offices, one in East Brunswick and one in Florham Park, although most of our therapists these days are working via telehealth. So if anyone's interested in more information about our practice, you can go to our website, which is www.stressandanxiety.com. Oh, you know what? Before I move forward, I forgot to have my little clock thingy ready in front of me so I don't go over time, because I know we want to save some time at the end for Q&A. And I also have to turn off the thing where I'm reading all these texts from my wife all of a sudden. So bear with me, guys, sorry. So live stuff. Okay, so our learning objectives for today is we want to know what is and is not OCD. We want to understand the mechanisms that maintain OCD, and learn about the gold standard for OCD treatment, which is sneak preview cognitive behavioral therapy. And coincidentally, the kind of therapy that I happen to do. Number 4, we want to learn about strategies for coping with the distress that can come from not engaging in compulsive behaviors. So OCD is obsessive compulsive disorder, and let's break down what that means. So we're going to start with obsessions. So an obsession is an unwanted thought, image, or impulse that causes marked anxiety or distress, and attempts to ignore, suppress, or neutralize are part of OCD. It's not simply excessive worry about real-life problems, so it's not what we would call generalized anxiety. It is often irrational kind of thoughts that pop into our head that overwhelm and frighten us. And it's recognized as a product of one's own mind. So usually, not always, people with OCD can say, I know this thought doesn't make sense. I know it sounds strange or far-fetched. I know it's impossible. So they'll often preface their explanation of what OCD is with statements like that, but then go into what are the thoughts that they're having, the beliefs they're having. Compulsions. Compulsions are repetitive behaviors or mental acts that are functionally related to the obsessions. And we'll talk in a moment about what do I mean by that. And those behaviors are aimed at reducing distress or preventing a dreaded event. So the main feature of a compulsion is trying to neutralize the anxiety that comes from the doubt that obsessions produce, the uncomfortable feelings, the uncomfortable thoughts. So the compulsion is aimed at neutralizing those sensations. Okay? And so disorder, we're going to talk a little bit tonight about why this word is highlighted as well in OCD. So if the obsessions and compulsions cause distress, dysfunction, or disorder, then it's OCD. Right? So as I said earlier, we're going to talk a little bit about the difference between what sometimes people refer to as OCD and what actually is clinically diagnosable as obsessive compulsive disorder. But first, we'll talk about some types of obsessions. Right? Now, keep in mind, there's lots of them. And so I didn't want to take up a lot of time listing all of the different kinds of obsessions that exist. But if people are interested, you can Google the Yale-Brown Obsessive Compulsive Scale, or that's called the Y-Box. So Y-BOCS, or the children's version, which is the Psy-Box. So CY-BOCS. And that gives you a pretty comprehensive checklist of different kinds of obsessions that people have, different kinds of compulsions that people have. Right? It also gives you a scoring system for rating how intense are the obsessions and how disruptive are the compulsions, right? So typically when you're working with somebody seeking treatment for OCD, these might be the kind of assessments that they ask you to complete. And I think it's really valuable to help clients see these so they have a sense of, what I'm suffering from is not unique, it's not unheard of, it's not that rare. See, it's right on that checklist that I'm showing you. So I think there's value in doing that, as well as sort of getting a baseline of at the beginning of treatment, how intense are the symptoms, and then measuring that throughout the course of treatment to make sure that we are able to have observable change in symptoms. But anyhow, in terms of types of obsessions that you might find on the Y-Box or the Psy-Box, there's contamination obsessions, perfectionism obsessions, symmetry obsessions. So that's a need for things to be even or straight. Homosexual OCD is more common than people thought. So that is a person who, let's say, they might be heterosexual, who suddenly develops obsessive thoughts that they might be gay. In fact, we can also have heterosexual OCD. So a gay person suddenly having doubts, intensive doubts, sort of intrusive thoughts that they might be straight. Right? And so we're not talking about the kinds of things that sometimes kids experience maybe when they're approaching adolescence or teenage years, where they have some, they're unsure about their sexuality. These are usually people who have pretty firmly established that they are either heterosexual or homosexual, but then suddenly one day these obsessive type of thoughts sink in and produce a lot of fear and discomfort. There's also relationship OCD. So relationship OCD is the kinds of thoughts like, do I really love this person? And then overthinking that, trying to feel the love, which then might produce a lot of anxiety if you start to have doubts. Do I really love this person? Now for children, that's usually the object of relationship OCD might be your parents. Do I really love mommy or daddy? What if I don't love them? I feel guilty about that, so I'm constantly checking to see if how do I actually feel about them? And then that overanalysis produces a lot of fear and becomes a compulsive behavior. Fear of harm to self or others. This is a really important one as well, because sometimes people might misconstrue what this is. And so I've worked with many people over the years who might have intrusive thoughts about harming somebody, right? And the thought horrifies them. It causes them distress, or fear that they might harm themselves, right? So that can be an obsession. Fear of loss of essence. So that is sort of the fear that somehow I will change. At its most extreme, I've had cases where people believe that literally if I touch a picture, I will literally become that person. My body will transform and become someone else. At its most common, fear of loss of essence is more like somehow I'll fundamentally change, right? That maybe I'll go from a person who's really kind-hearted and friendly to a person who's mean if I don't do certain compulsions. And then the last one that I'm listing here tonight, but again, keep in mind there's so many more. These are just some of the more common ones that we are aware of, is scrupulosity or religiosity. So this is an excessive fear that you may have offended God or done something immoral or unethical. So let's talk about the types of compulsions that can line up with that. So if you have a fear of contamination, then one of your compulsions might be excessive washing or cleaning. So taking long showers, washing your hands a lot, using a lot of Lysol or cleaning sprays to clean surfaces or kill germs. Sometimes people even use this to contamination fears that aren't related to germs. So I've worked over the years with people who have contamination, not because they're afraid of getting sick, but maybe the idea that somebody else is distasteful to them or gross to them. And if they touch something that they touched, it makes them feel uncomfortable. So they'll spray an object with Lysol as if that's somehow killing the discomfort, if that makes any sense. Avoidance is a very common compulsion that people don't talk much about. So again, an example of this is if a person believes that an object is contaminated, they might avoid touching it, right? Repeating behaviors, right? So having to do things over and over again. Sometimes it's a byproduct of just sort of having an intrusive thought that if I don't do this, something bad's going to happen. Sometimes it's more of a feeling, right? It feels wrong if I don't do something a certain way, so I'm going to keep doing it over and over again until it feels right. Checking compulsions, right? So going back and making sure that you did something correctly. So a common one might be a person who's afraid that they didn't lock the door, might go back and check their door over and over and over again. Even though it's clearly established the door is locked, they might go back several times to the point where maybe they're late for something. Touching compulsions. So an example, I used to work with somebody many years ago who would have to touch their nose in a certain sequence because their OCD would tell them, the obsession, the intrusive thought was, if I don't, my loved one will die of cancer, right? So they would engage in this behavior, not because obviously touching your nose doesn't actually prevent people from getting cancer, but it really made the thought, the discomfort go away. It gave the person the illusion of control over a thing that wasn't happening. By the way, this particular client, the loved one didn't have cancer, but the thought was so distressing that they engaged in a behavior that gave them the illusion of control. Counting rituals, right? So sometimes people might have to count to a certain number before they complete an action, because their OCD says if you don't, something bad will happen. Or they may have to count objects. So counting can become a compulsion. Mental rituals like prayer, well, that would line up with scrupulosity or religiosity, right? The idea of I may have offended God, so I'm going to have to pray for forgiveness, or I might have to only, I can't perform certain behaviors unless I'm only having a pure thought, right? Now, the problem with that is, think of it like a pink elephant phenomenon, right? If we tell ourselves not to think about pink elephants, what do we think about? We think about pink elephants. If we tell ourselves we're only allowed to have pure thoughts, then sometimes we might start to have impure thoughts, right? So sometimes people who have mental rituals related to compulsion, to religiosity, might have to only think pure thoughts before they can complete a ritual. Mental review. This might be like trying to remember, to retrace your steps, right? So if a person is afraid of contamination, they might they might suddenly have a doubt, did I touch that toilet seat, right? That looked dirty? Did I clean it thoroughly before I sat down? They might mentally review, like maybe that bathroom that they used an hour ago. They might go through their head and try to remember how many squares of toilet paper did I use? Did I get every single nook and cranny of the toilet paper? So again, there might be reliving or mental reviewing as a compulsion. And again, this is just a sliver of the kind of things that people with OCD could experience. Now, I really did want to make sure that we talk tonight about the difference between somebody saying something like, I'm so OCD, versus they actually have the diagnosis of obsessive compulsive disorder. So people who say this are often referring to tendencies or habits, but it's probably not OCD, and it actually minimizes how much people who actually have OCD suffer, right? Some people would even say it's kind of offensive to a person who actually has OCD and is suffering tremendously for somebody to say, oh, I'm so OCD, or I have OCD. Right. So some examples of probably not OCD, I should say, even though a person says I'm so OCD, might be being organized. Nothing wrong with being organized, right? Liking things a certain way. In and of itself, there's nothing wrong with things being a certain way. Being cleanly, that doesn't mean you have OCD, right? Generalized anxiety. So a person could be a worrier. They might, so they'll say, oh, I'm obsessing about that test that I did poorly on the day before. Or I'm obsessing about, will I get into the college I want to go to, right? that's more of an anxiety thing than it is an OCD thing, because there's no clear compulsion. There's no sort of irrational behavior aimed at eradicating the anxiety, right? And of course, as a lot of us know, tics and stereotype movements are not OCD, right? And it can be confusing because sometimes it's hard to differentiate. So for those of you who don't know, stereotype movement, they're often seen in folks on the autism spectrum. So these can be sort of rhythmic movements like flapping your arms, rocking back and forth, etc. Right? Now, that's not to say that couldn't be a compulsion, right? But typically we wouldn't identify that as OCD if people were doing that as part of a different disorder that they might be struggling with, right? And to give you an example of what do I mean by sort of tendencies or preferences, I actually have one of my own. I prefer things to be even, right? And so I have this weird little tendency. I actually literally just did it about 2 weeks ago, where anytime I buy dress shoes, I always buy a black pair and a brown pair. And I take turns. So the next time I'm going to wear dress shoes, today I wore black dress shoes. So tomorrow, if I were to wear dress shoes, I would wear the brown pair, right? So I like things to be even. I like each shoe to have its own turn so that I'm being fair to both pairs of shoes. Now, again, this doesn't cause me distress. This doesn't cause me dysfunction. So if tomorrow I decided, you know what, I'll wear the black shoes, or if tomorrow somebody said, oh, please make sure you wear black shoes because the event requires it, that wouldn't bother me. I wouldn't struggle with it. It wouldn't cause me a lot of distress or anxiety or dysfunction. But let's say if I did have OCD, right, and maybe if that was my OCD, I might be paralyzed by, like, I can't wear the black shoes tomorrow because something terrible will happen if I do. So that's the difference, right? So I have a tendency, I have a preference, but there's no distressed component to that. So even though we could say, oh, there's an obsession with evenness and the compulsion is taking turns with the shoes, it doesn't in any way functionally interfere with me, and I can easily not do it. Again, now let's talk about I have OCD. So some examples of actual OCD might be spending hours organizing and agonizing over doing it correctly and being late for things because you don't feel like you can stop. That's a clear example of a person struggling with OCD. Arranging objects in a certain way and melting down if someone moves it because it took you forever to get it right. That would be an example of OCD. Washing your hands so often that your skin is damaged, or using chemicals to clean things and the thing gets ruined. I've worked with many clients over the years, and they often think that they're the only ones. I've worked with many clients who have had gone through numerous computers because they're constantly cleaning the keyboard because it feels contaminated, but then some of those chemicals seep in underneath the keyboard and damage I'm not a tech guy, so I guess we'd call it the motherboard underneath. So that would be again an example of the compulsion causing a lot of disorder, distress, destruction in this case, right? So a lot of Ds. Some more examples of I have OCD. Fearing that certain thoughts offend God, so you pray all day long or repeat actions until your thoughts are pure. Fearing you could lose control and harm someone, so you'll stay away from sharp objects, avoid being alone with loved ones, and are constantly trying to figure out if you are actually dangerous to somebody. I've seen a lot of that over the years. I actually really enjoy treating it because, you know, it's great to see people who suffer so much get a lot better. Fear that you said something racist. So you try to remember every word you said during conversation. Now, again, this would typically be a person who isn't racist, doesn't say racist things, but their OCD might say, hey, during that conversation, are you sure you didn't say something racist? And they'll be so distressed by the idea that they start mentally reviewing, trying to remember the entire conversation word for word. At its worst, they might start texting people, hey, during our conversation, did I say anything that offended you or that sounded weird, right? So things like that would be compulsive and again, sort of a clear example of OCD. Fear that you don't really love someone, so you keep trying to figure out how you feel or constantly need to prove it to yourself, right? Now, it's really hard to be in touch with your feelings of love if you're also having a panic attack, right? So sometimes when people have OCD, the idea that maybe I don't love this person causes such intense anxiety and panic that they can't access those loving feelings, and it almost in their mind fuels the idea of maybe I don't love them, and then they go back into compulsive trying to figure it out, right? One of the things that we really try and teach our patients to understand is OCD is all about doubt, right? And so the key to the therapy is helping them learn how to tolerate doubt, or practice tolerating doubt, I should say. So I like to call this slide the perfectionism example. Some of you may have noticed, some of you might not have, that throughout the slides so far, there have been a few grammatical errors, spelling errors, inconsistencies in formatting, right? And some of them are intentional, some of them I may have missed, or some of them I kind of noticed, but I was just too lazy to fix. Uh, so if you noticed it or it annoys you, that doesn't mean you have OCD, right? I'm pretty sure that somebody must have noticed that I misspelled perfectionism on one of the previous slides, right? Now, if you were the one creating the presentation and it took you several hours extra to prepare it because you are checking, rechecking, constantly making sure that you didn't make any errors, right? Excessively bothered by formatting errors and things not looking right, then that might be, again, a clear example of OCD. So, and by the way, just another plug for New Jersey Center for Tourette Syndrome. I am just one of the many participants in the Wednesday webinar series. One of the really brilliant doctors in our practice, Dr. Deborah Schur, recently, a few weeks ago, gave a presentation on perfectionism, which is, again, a specific form of OCD. And she talks a lot about what a major struggle that is for some kids with OCD and adults with OCD as well. One of the things that I really like to talk about with folks who struggle with perfectionism is that we're trying to teach them to pursue excellence rather than perfection. And we talk about how the pursuit of perfection really interferes with your ability to be excellent because it's overwhelming, it's burdensome, it takes excessive amounts of time. Often perfectionists can't get homework done in time because they spend so much time trying to make sure it's perfect. I've had perfectionists who won't hand in homework because they'd rather get a 0 than hand in something that isn't perfect, right? So again, we talk about how perfectionism actually gets in the way of pursuing excellence rather than making you perfect. So for more on perfectionism, go to njcts.org and look up their webinar series. So as I mentioned earlier, I am a cognitive behavioral therapist for OCD. And we wanted to talk a little bit briefly about the efficacy. So CBT for OCD has been around for approximately 50 years and is the most empirically supported form of psychotherapy for OCD. So what does that mean? There's been a lot of studies because it follows a certain protocol, right? And so when therapies follow specific steps, there's a treatment manual, there's a protocol. You can compare it to a placebo, you can compare it to medication, you can compare it to other therapies that also have replicable formats, right? And so consistently over years, various studies have shown that 65 to 80% of clients who complete treatment show a statistically significant reduction in symptoms. On average, treatment can last up to 16 sessions, and most experience significant improvement by session 8, but results in treatment and treatment length can vary. But again, the really important point is that there is no other form of psychotherapy that has this much research behind it that says this is really effective. And so that's why it's considered largely the gold standard. And don't take my word for it. If you guys were to Google treatment for OCD, you're going to see a lot of references to CBT, cognitive behavioral therapy. You're also going to see a lot of references to something that I'm about to talk about. Might be the next slide. Nope, I'll talk about it in a few slides, sorry. So we also, of course, when we work with kids, we want to equip them with tools. So a really simple tool is a fear thermometer, right? So we want to ask kids that we work with, how difficult is it to do something, right? And we give them ratings. So 1 being no problem, 3, I'm a little uneasy, 5, maybe I can resist, but I'm not sure, 7, I don't think so, 9, it's really hard, 10, no way, impossible, right? Some kids have a hard time, or actually perfectionists might overthink, right, the scale, right? I don't know, maybe it's a 5, but maybe it's a 4, maybe it's a 2, I don't know. And so with kids like that, I might give them more of a like a green, yellow, red, right? Or cold, getting warm or hot. But we can find different creative ways to help them rate how difficult would certain things be for them. How difficult are certain things? Typically normal behaviors, but might be made difficult for them. So if, again, going back to an example I'll probably reference a lot tonight, if you have a fear of contamination or germs, I might ask somebody, how difficult would it be for you to touch that doorknob and not wash your hands? And I want them to give me a score. And if they say that's a 10, then I might ask them some easier versions. What about this? What about this? And so we really want to have a robust hierarchy with lots of different options in terms of different behaviors that we can work towards. So speaking of hierarchy, so again, I might have clients and parents, of course, are going to be a big help with this, because especially with younger kids, they may have a harder time explaining themselves or listing or even acknowledging or understanding that they have OCD. So I would want them to list maybe, like, let's start with the five situations that cause me distress, anxiety, or the urge to ritualize. And again, with kids, I might use more kid-friendly terminology. So I wouldn't say urge to ritualize, but I might talk about habits that they'd have to engage in, like, washing your hands after you touch a pen that belonged to somebody else, right? How much anxiety would it cause you to touch that pen, right? You can see in the bottom part, describe 5 rituals. Again, I might use habits you engage in and how much time they take and how often you do them. This is a good thing for us to list because it also aids motivation. We want to help people really get in touch with, like, how time consuming and how difficult it is. So if somebody could put on this list, it takes me an hour to shower because I can't get out until I feel perfectly clean. And then they might say, after I shower and I am perfectly clean, I have to be extremely careful before I go into my bedroom, because if I accidentally bump up against something, now I'm contaminated and I either have to take a shower again or I can't go into my bedroom because I run the risk of contaminating my bedroom, right? So again, it's really great to have kids and adults list, what are the rituals, how time consuming are they, how disruptive are they? And so it really sets the stage for what we want to do. And that's anthropomorphizing OCD. Oh, I said that word correctly. I can almost always struggle to nail it. So what is anthropomorphizing? It's teaching kids to see their fears as a bully that's bossing them around. And we often have the kids give that bully a name and teach the child that we're going to be bossing back. And we boss back by ignoring what the bully's telling us to do or do the opposite of what the bully tells us to do, right? So I think SpongeBob is still popular, but if not, okay, sorry for the dated reference. But this is a drawing of one of the characters in SpongeBob called Plankton. And Plankton, if you ever watch SpongeBob, has like this nefarious, scary, deep voice. And he has all these plots to steal the Krabby Patties and what have you. But then one of the things we try and help kids realize is Plankton is actually very small. He's not strong enough to actually do any harm, but he talks a big game. And so that's, again, kind of how we want to frame OCD. So sometimes we have people draw things in therapy. So these were donated by clients over the years who gave us permission to share these slides. So this person drew a monster. This is a very New Jersey term for any of you who are watching from outside of Jersey, scooch, right? So I'm not Italian. The name sounds Italian. I'm actually Colombian. But I've been told by my Italian friends that scooch is something that's like annoying, or, a pest, right? So there's scooch. You do what I say, says scooch. Mr. Pushy. By the way, this was drawn in February 2000 by somebody who I think was like 7 or 8 at the time. So this kid is probably in their like late 20s, early 30s. Yeah, I'm not good at math, but I'm not a perfectionist, so who cares? So here's Mr. Pushy. He's roaring. He's in animal formation. He's got claws and sharp teeth and spikes all over. So again, we really want to help kids identify this is our enemy. This is the person who's pushing us around, bossing us around, telling us what to do. And we're going to push them back. We're going to boss back. We're not letting him or her control us anymore. So again, we want to help them stand up to the bully. And so we often use metaphors and storytelling a lot in our practice. So we might use the metaphor of, if a bully threatens you for money, what do you do? What happens if you give in, right? Now the problem is, if you give the bully money, he learns or she learns, if I threaten you every day, I'll get more money out of you. They're usually not reasonable. They don't go, oh, this nice lad gave me $1. I think I'll take it and put it in my piggy bank and never bother him again. That's not how bullies operate, right? Now, sometimes because bullies are scary, we could say, well, I could hide, I could avoid, which again is a compulsion. But what we know is avoidance is a compulsion that doesn't do anything to prevent the bully from being a major factor in our lives. And that means we have to spend the rest of the school year, if we stick with the metaphor, hiding from the bully. And that's really unpleasant. That's really anxiety provoking, right? So we instead talk about what happens when you fight back, right? And it turns out the bullies don't like going after the kids who fight back. They're a lot more work, right? That doesn't mean you might not get punched. So sometimes fighting back hurts. It's difficult. It's uncomfortable. But we want to teach kids that in the long run, it's the best thing to do so that the bully doesn't control our lives. So again, this is another drawing on the right, is the bully saying, go wash your hands. And this is the child saying, no, I won't listen to you. So with younger kids, I think that, again, these are really good examples that sort of set them up for the work we want them to do. I also use storytelling a lot. So one of the stories I share is, what would you say, and this is about sort of responding to your OCD with logic, which never works, right? So if your OCD says, you're the Queen of France, right? Well, I could try and convince OCD that I'm not the Queen of France. I could say, well, how could I be the Queen of France? I'm a guy, right? And I was born in Plainfield, New Jersey, and my parents are Colombian, and we've never even been to France. Like, how could I possibly be the Queen of France? And OCD is just going to look at me and go, nah, you're the Queen of France. And then I could say, well, let me show you my birth certificate. See, I was born in Plainfield, New Jersey, like I told you, right? Nah, you're the Queen of France. And it's never going to stop. So the more we talk with OCD, the more we interact with it, all we're doing is we're getting its attention, and that's what the bully wants from us. It wants us to do what we tell it to do, and it wants a lot of our attention. So we don't want to keep this conversation going. So metaphorically speaking, what we do is sometimes when OCD says, oh, you're the Queen of France, it says something that we know sounds irrational and illogical. We have to learn to just say, yeah, maybe, and we walk away. So that's an example of sort of resisting trying to eliminate doubt. Instead, we respond with a doubting phrase. Maybe, yeah, we'll see, I don't know. We're not trying to gain certainty, because OCD is the desperate attempt to get certainty around doubt. Oh, I doubt that I'm feeling this doubt that I might get diseases from touching pens and doorknobs, so I'm going to wash my hands until the doubt goes away, versus just being able to say, I acknowledge it's really, really, really unlikely that I'll get AIDS from that doorknob, so I'm going to touch it. And if OCD goes, you're going to get AIDS, as creepy as it sounds, we're not going to wash our hands, and we're just going to say, yeah, maybe. Don't feed the cats. Our fears behave like meowing cats asking to be fed. If we feed the cat, it comes back the next day and brings its friends. So so often I ask kids, well, what should we do if the cat has learned that when it meows, you're going to feed it? And every kid will say, oh, you have to stop feeding it, right? Now, that doesn't mean the cats go away right away. Maybe the first few nights they meow even louder because they're just thinking, hey, this person forgot to give me my cat food. I need to get their attention. But I tell people that if we stick to our guns, right, I got to get rid of that term, by the way. If we commit to not giving in, eventually the cat goes away. And again, that's like a metaphor for OCD. When we don't give in to compulsions, right? When we don't keep giving the cat what it wants, or in this case, I'm sorry, when we don't give OCD the compulsions, when we don't give it what it wants, it does weaken and eventually fades away. Now, that doesn't mean we cure OCD. Something new might pop up, but at least now we know how to respond to it more effectively. So all of this that I've been talking about is what we call exposure and response prevention. So in a lot of research, when I was in grad school, you would always see ERP, and more recently, they often write EXRP. But again, both stand for exposure and response prevention, right? Sometimes people say exposure with response prevention as well. So basically, whatever OCD tells you to do, you do the opposite. So you trigger your anxiety on purpose, and you don't do compulsions to make the anxiety go away, right? So that might sound weird. Why would I trigger my anxiety on purpose, right? And so we have to do a really good job of explaining why it's going to help, how it's going to help, right? So what are some forms of exposure? So I often explain the difference between scheduled exposure versus serendipitous exposure. So scheduled exposure might be, let's say the person who believes that if I don't touch my nose 3 times every time the phone rings, that someone will die. Well, scheduled exposure might be, I'm going to call you at a certain time and you can't touch your nose, right? You're just going to have to sit there and deal with the anxiety you experience, because again, we're going to try and remind, especially with younger children who may not get it, we're going to try and remind them, touching your nose has nothing to do with whether or not somebody lives or dies. It's really about OCD being a mean bully who's messing with you and trying to get you to do silly things by scaring you. But we're going to be brave, and we're not going to give in and do irrational things that don't make sense. But when we do scheduled exposure, we're going to pick the fight with the bully. We're going to trigger the discomfort, but not give into it. Now, serendipitous is more like when it happens by accident. So I had a great example not too long ago where a client that I worked with who has contamination OCD tripped and accidentally touched a wall that he thought somebody might have sneezed on, right? So he hadn't planned on it, right? In fact, he usually kind of stays away from the walls because he just, in his mind, surfaces are contaminated. but he tripped. His hand touched it, and I was really proud of him because he made a decision not to wash his hands. And in fact, he went around and like he used his pen, he touched his book bag, he spread the contamination, right? So once he did that, he realized, oh, I can handle these feelings, right? Now, in terms of, so not just how to, when exposure can occur, but there's three types of exposure we often talk about. One is in vivo. That's when, again, we literally do the thing that makes us uncomfortable, right? So if you have germ fears, you touch the thing that you think has germs, right? If you have negative thoughts and you want to tap your nose, I make you think the negative thought on purpose and don't tap your nose. So we're making you do the thing that makes you uncomfortable, and we're not allowing you to do, or you're choosing, I should say, you're choosing not to do the compulsion, right? So that's in vivo exposure. Imaginal is an add-on. So we might imagine the thing that makes us really uncomfortable. So as dark as this might sound, the person who's afraid that a loved one will die if they don't tap their nose, I might have the client close their eyes and imagine that loved one dying, and they're just standing there with their arms folded, and it's their fault because they didn't touch their nose, right? Again, we only do this if we have a strong sense that people know this doesn't make sense, and they understand it's just an uncomfortable thought. This couldn't actually happen, right? Now, as a side note, we don't want to talk too much about that because we don't want to reassure them that it's definitely not going to happen. We're just sort of starting with the idea of, I know it's not going to happen, and now I'm just going to do it anyway, and I'm not going to reassure myself. Now, scripting, similar to imaginal exposure, you might write a story. Sometimes we refer to it as a flooding script. So again, the person might write a story and read the story, repeat the story several times about, again, that like, I didn't touch my nose when I could have, and I was right all along that I had some sort of magic power, and because of that, my loved one passed away, and it's all my fault, and everybody's going to hate me, and I'm a terrible person because it would have been so easy for me to touch my nose. So we're really laying it on thick. We're really telling the horror story that the person tries to avoid by engaging in compulsions, right? So these are all different forms of exposure and response prevention. So why would I do something that makes me feel bad? And the answer is because it helps. By facing our fears, our bodies get used to the uncomfortable sensations. This is often called habituation or desensitization. So I have a slide here. The images of people jumping into an ice, I guess like an ice hole somewhere, right? Make sure I pronounce that properly, ice hole. So, and so the metaphor that I give folks that I work with when explaining exposure therapy is I say, have you ever jumped into a swimming pool that was a little bit too cold? And they say, sure. And I'll say, what does your body want to do? And they'll typically tell me, oh, I want to jump out. It's too cold. I don't like how it feels. And I say, well, what happens if you stay in the pool anyway? And they say, eventually I get used to it. So it's not that the water gets warmer, it's that our bodies habituate or desensitize to the cold water, right? Now I'll ask them the opposite. What happens if you jump out of the pool, right? Well, then I'll never get used to the temperature of the water if I keep jumping out. So when kids do compulsions, they deny themselves the opportunity to see that the anxiety won't persist forever. It can go away without resorting to rituals, that feared outcomes about getting sick from using a public washroom, for example, are highly unlikely to occur. Now, one of the most important questions that we ask after having somebody do their ERP exercise is, what did you learn from that experience, right? They'll often talk about how awful it was. I felt really bad. I really hated it. I don't want to do that again. But we can also say, but what you learned is you're resilient. You could handle the uncomfortable feelings. If we're lucky, by the end of the session, they might be able to say, I'm not that anxious anymore. I feel okay, right? But even if they leave the room feeling still anxious, I know they're going to come back next week, hopefully. And I might ask them, so what was the week like? Were you in a state of terror for the entire week? And almost always they'll say, no, not really. It got a little bit better, like maybe the next day. And so even then we can say, great, that proves that exposure works, right? That you can do difficult things. You don't have to do compulsions, which strengthens and feeds your OCD, and you can tolerate that discomfort. So that's what we can learn. So we want to teach them about the vicious cycle of OCD. So when we have OCD, we might be exposed to a trigger, some kind of intrusive thought or some sort of thing makes us think the uncomfortable thought, and our anxiety starts to climb, right? Now, if we engage in avoidance behavior, that would be a compulsion. Our anxiety does drop quickly, but the thing is we never have the opportunity to habituate or desensitize. And the next time the trigger happens, the whole process happens again and nothing changes, right? So I say to my clients, I understand why you do compulsions. Who wouldn't initially, right? I feel really uncomfortable. I wash my hands. I don't feel uncomfortable anymore. I feel really scared. I tap my nose and I spin 3 times and I'm not scared anymore. Makes sense and it's so easy to do, right? But the problem is OCD often spirals out of control and it demands more and more of your time and it becomes more dysfunctional, more disruptive, and it extends to more and more triggers, right? So it's actually really important that we help them get over this peak. Now, what happens when they do? So this is the outcome of repeated exposure and response prevention. Again, response prevention is important because that's when we bail out. So let's say the first time we do exposure, we climb that curve, the panic peaks, but then it comes down, right? And it starts to get easier. And we start to see that, okay, I can handle having anxiety, even if it's really intense, but I don't have to do a compulsion to make it go away. I just have to wait it out. And then if we keep doing it repeatedly, it just gets easier and easier. You see the curve doesn't peak quite as much, and it doesn't take quite as long for the anxiety to go down. So again, that's habituation. So how do I deal with the anxiety? That's a really hard thing, right? We're asking people to do something that makes them really uncomfortable. So we start by making sure we aren't unintentionally sustaining it. That's really important. So often clients will tell me, I did exposure, Dr. Zambrano, and I didn't feel better. I didn't desensitize. It felt horrible. And I ended up washing my hands or tapping my nose or doing some sort of irrational compulsion, right? And you know, sometimes they say, and I waited hours and it didn't go away, it didn't get better, right? So one of the first things I want to ask them is, might they be doing a compulsion? Again, because this is called exposure and response prevention, not exposure and go wash your hands right away, right? But often people don't realize they're doing compulsions, right? So maybe if they're seeking reassurance, if they touch a doorknob and they're asking their parents, are you sure I'm going to be okay? You don't think I'm going to get AIDS, right? Now they're thinking about it, they're talking about it, they're obsessing about it, they're fueling their fear, right? They're staying engaged with the anxiety rather than sort of just allowing themselves to experience it and watching it fade away, right? And so when people do compulsions, one of the metaphors I use is I say, I'd rather you not do exposure if you're going to do a compulsion afterwards. It's like eating a bag of Oreos while running on a treadmill, right? It's counterproductive. If you're running on the treadmill because you want to get in shape, but you're eating that bag of Oreos at the same time, what's the point, right? I mean, Oreos are pretty awesome, but it probably is counterproductive to our goals, right? Now, what do I mean by don't shake the snow globe, right? One of the things that we try and teach people is not how do I make the anxiety go away, because that sells the idea that you should make your anxiety go, that anxiety is a bad thing that you can't handle, versus it's a natural, normal part of our brain's design, and that all we have to do is sit still, right? So think of a snow globe, right? Usually when you see a snow globe just sitting there, all the snow is on the bottom, but if you pick it up and you shake it, then we see the snow all over the place, right? And that's kind of how our emotions can be when our OCD is triggered, right? It really shakes us, and now we're kind of in this swirl, this snowstorm of emotion, right? Now the problem is, if we're doing compulsions, or if we're doing mental rituals, or if we're preoccupied with the anxiety and fixating on it, what we're really doing is we keep shaking the globe over and over and over again. And we know what happens when we keep shaking snow globes. The snow never is allowed to settle, right? And so again, this is a thing that I try and teach my clients, is that you may be unintentionally shaking that snow globe without realizing it, by trying to reassure yourself, by trying to resist and suppress your feelings. And even a simple relaxation technique, honestly, can be an attempt to suppress feelings. So instead, we try and teach people to deal with it differently. So I teach them to ride the wave. So instead, we might teach them to patiently sit and watch their feelings using mindfulness techniques, right? So if I have somebody do exposure and they say, okay, I feel really anxious, I really want to go wash my hands, I say, well, let's see if you can sit with me. Let's see if we can delay just a little bit longer. And I'll ask them, where do you feel the anxiety? And they'll say, oh, my heart's pounding, my stomach is in knots, I feel nauseous. Okay, let's sit there for like a minute, and I'll pull out my timer, my stopwatch. I'll say, I want you to sit there for a minute. I want you to really focus on those feelings. I want you to notice your heart pounding. I want you to feel that knot in your stomach and just explore it, almost like an explorer who's curious about it, right? And what that does is that it switches up the relationship. Instead of trying to suppress it or be afraid of it, they're kind of just like willing to experience it and watch it. And if they do it long enough, then I might say after that 1 minute, okay, now let's just sit here with those feelings. You don't have to focus on it like I asked you to for that whole minute. And good job. You did a great job sitting there with it for a minute. You usually don't do that, right? But I had you really, really focus on it, and you're still here. You're still okay. Now let's kind of just switch to, while you're feeling this, tell me what else you can feel, right? What else do you notice? So they might say, well, my stomach is still in knots. Okay, what else? Well, the room's kind of cold. Okay, what else? My throat's kind of dry. Okay, what else? My lips are a little chapped. Okay, what else? I'm sitting on this chair and it's really cushiony. Okay, what else? Now, if you're an old person like me, my hip feels kind of sore. But if it's a young kid, it might be like, what do you smell? What do you see? What do you hear? Now, we're not trying to distract them. So I don't want you guys to get confused. It's not about distraction. It's about, okay, we're going to sit here with these really uncomfortable feelings, but they're not the only feelings that are present. They're not the only thoughts or sensations that are present, right? And that, but in doing this, sometimes people just notice that, oh, my stomach doesn't hurt as much anymore. My heart's not pounding as hard as it used to, right? And it also has the added benefit of sort of maybe by focusing more on what's present, we don't go into the place where we're thinking about what we just did too much, right? And so it maybe just sort of allows the snow globe to settle. On the other hand, sometimes we can add an exposure to the exposure. So sometimes adding imaginal exposure and or scripting helps desensitization happen more quickly, right? So a person might touch the doorknob and again, think, oh no, that doorknob was covered, that doorknob's going to give me AIDS. That's a thought that's distressing, right? So I might say, okay, let's touch the doorknob when you were at that part of the hierarchy, and let's maybe kind of just go all in. You're going to close your eyes and imagine, and now I have AIDS, and I imagine the doctor telling me, oh, you shouldn't have touched that doorknob, right? Because it was covered in AIDS, and your hand had a huge gash on it that you somehow didn't notice, and now. And again, I know this sounds really intense. Obviously, we're going to do it in an age-appropriate way, depending on who we're working with, right? But the idea is we can add an exposure to an exposure. We can imagine something. We can tell a story. Sometimes we tell the story in a very vivid way, but it helps us get in touch with how ridiculous the story might sound or how far-fetched and unlikely it is. We're almost out of time before Q&A. So in terms of OCD treatment goals, we want to teach people not to suppress anxiety or make it go away, but rather we're learning how to function in spite of the anxiety and trusting that it goes away on its own. And heck, even if it doesn't, then, or not as quickly as you want it to, then when we learn, we're resilient. I can manage some level of anxiety and still function and do all the things that are meaningful to me that I want to do, and I'm not going to let OCD stop me, right? So again, our goal is to manage, not eliminate uncomfortable feelings. Some rules for exposure for families, this is really important. It's helpful to assess how much a child believes their obsessions, as this can be a major obstacle to ERP. So there's no way I'm going to get somebody to touch the doorknob if they 100% actually think they're going to die, right? But if I can get them to say, I know it's far-fetched, it's really unlikely, and I'm willing to take the risk, right? Usually people only are willing to take the risk if they can acknowledge the risk is pretty small, right? And I often use the metaphor of like, well, did you drive in a car today? Most days people do, right? And I ask them, could you have died in a car accident today, right? And they'll typically say, yeah, that happened, it's possible. And I'll say, so you took a risk. You took a risk of something terrible happening. And it turns out for us to live normal lives, we have to be able to take risks every day. And I would think that there's a greater chance that somebody will die from a car accident than they will from a doorknob. So again, these are the kinds of sort of ways that we help people get in touch with, how unrealistic their obsessions are, and maybe that motivates them to take these risks because they're not really risks. They're so infinitesimally unlikely to happen that we try and get them to take that leap of faith. Families may have to figure out if they're somehow enabling avoidant behaviors or rituals and work on slowly pulling out of such behaviors. And we then provide the child with specifics and deadlines. So one example, again, might be the parent who, the child who's afraid that something terrible will happen to their parent. So the parent maybe sleeps in the same room with them because they're too afraid to be separated, right? That's an enabling behavior that sustains the fear. The parent who buys the child tons and tons of paper products and cleaning products so that they can clean the house excessively to the child's standards. I get why parents do it. They don't want their children to suffer, but in the long run, it gets in the way of the therapy and it enables and feeds the OCD. Now, a child should never be forced to do ERP. ERP should never be a surprise. So if a person has, um, again, a superstitious fear, for example, like that if I drive past a graveyard, somebody I love will die, right? I wouldn't say the parent should like drag the child into the car and then we're going to drive past graveyards, like it or not. That should be something that we're trying to get the child to agree to work on, right? So ERP should never be forced. It should never be a surprise. But maybe, again, we can create situations by not enabling it where the child is kind of has no other choice, right? But to, okay, I'm going to have to confront this. And we also want to make sure that everybody understands that OCD only wins if you don't try to fight it. We're going to have a lot of missteps. We're going to have a lot of struggles. It's not always going to be a straight line to improvement, but we have to be patient and have realistic goals. Don't take no for an answer. If the child says, I can't do it, then find out what they can do. Can't touch that doorknob? Okay. What if I touched a tissue to the doorknob? Could you then touch the tissue? Can't do that? What if I touched a tissue to the doorknob and then touched a pen to the tissue and then touched the pen that touched the tissue that touched the doorknob touched to another tissue? If we try hard enough, I can find something that the child will say, this makes me uncomfortable, but it doesn't overwhelm me. And that's usually a good starting point. If the child can't 100% prevent themselves from engaging in a ritual, then the goal is to delay or alter the ritual. Whenever possible, inject humor and celebrate all successes. Be sure you are always pointing out the progress your child is making. No step is too small so long as we keep moving forward, right? So this is really important for parents because you could get frustrated how long it's taking, but if we're seeing forward movement, if we're seeing progress, we want to encourage it while continuing to push. I believe you can do so much more. Let's keep at it. So our job is to motivate and push, but not force against somebody's will. If there's motivation issues, we want to help children understand what anxiety stops them from being able to do, right? Not being able to do these things makes me feel blank. Some things I'd like to do when I am less anxious are blank, right? So again, helping them sort of really see what an obstacle OCD is and how much better life can be after they've dealt with it properly. We want to empathize with the child's fears, but give them the confidence that you believe that they can get better and you will help in this process. You may have to include a system of rewards for participating in ERP therapy. So that brings us to the end of the presentation. You guys have copies of my slides. So some suggested readings. My boss, the head of our practice, Dr. Alan Wegg, wrote a really fantastic book called OCD Treatment Through Storytelling. We, in our practice, use this a lot. Aureen Wagner, who I have some slides from her previous presentation, she writes a really good book for younger children called Up and Down the Worry Hill. There's also OCD in Children and Adolescents, a cognitive behavioral treatment manual. This is an excellent guide for therapists who want to understand more about how to treat OCD that I'd highly recommend. John March, also a big name in our field, Talking Back to OCD. And this is more sort of for like adolescents. So that brings me to the end of this portion of the presentation. And thanks for listening, everybody. So do we have any questions?
Rob, first and foremost, thank you so much. We greatly appreciate you coming and facilitating this webinar. So we do have a couple of questions.
Awesome.
Our first question is, how can you tell if it is OCD or a phobia? My son seems like he has a fear of fruit. If someone touches an apple, they have to wash their hands before touching something that he will touch.
It sounds like a contamination OCD, right? Mm-hmm. So if I understood Kitty correctly, that if someone else touches the apple, then they have to wash their hands or clean the surface, right? So phobia would be more like if I'm exposed to the apple or the fruit and it frightens me, but there's no actual compulsion involved, no like cleaning behavior. If it's just avoidance, then I'd say that's more of a phobia. If it's I am now making people clean, or doing some sort of ritualistic type of behavior to negate that anxiety, then that's OCD.
Okay, thank you. Next question is, I find that talking to myself gets me through. You say don't talk to it. I logic myself out of stuff to a point I can function. Please comment on this, given your comment on not talking to it.
Sure. I think if you have OCD and you're logicking your way out of it, let's refer back to that slide where we talk about the D and the disorder. right? If it's a simple phrase that you can say, okay, I know that's not realistic, I would never do that, or that's impossible or unlikely, I don't have a big problem with that, right? If you are constantly doing it throughout the day, right? If you're constantly having to reassure yourself, spending a lot of time thinking about it to the point that you're driven to distraction or it gets in the way of getting stuff done, then we could say, well, that's problematic because it's a compulsion, right? Versus at some point we have to just be able to say, that is so far-fetched, that is so unlikely, just like, and that's the Queen of France story, right? If somebody accuses me of being the Queen of France, um, I don't have to prove anything to them. I know I'm not the Queen of France. It's ridiculous for me to have to present evidence. Um, and I know maybe my desire is I want this person to stop calling me the Queen of France, so I'll present all my data and information over and over again, and maybe that person will shut up and go away, right? But then I'm going to have to do it again the next time he shows up, right? So perhaps at some point I have to just be willing to say, okay, and I have to be really disciplined about just sort of again knowing this is so unlikely, this is so far-fetched, this is outside of the realm of um, realistic probability that it really is okay to ignore it, even though it feels uncomfortable, right? Anything more we would consider a compulsion.
Awesome, thank you. So our next question is, what do you recommend about working through 12-step programs with co-occurring OCD/moral scrupulosity, focusing on OCD first?
Hmm. I'm not sure I know what the questioner means about a 12-step program. Um, so
We
sorry if I
can
can't give a really effective response.
we can come back to that. I can also post it under with a little bit more information on the webinar log. So I'm just going to go to the next
Okay.
one then.
Do we still do
So
that thing where after the fact I might answer some questions? I know we used to do that in the old days.
yeah, no,
Okay.
definitely.
So I'm so sorry. I hate to disappoint, but I can maybe I'll flesh out that question when maybe it'll be easier to process when I see it in writing. So sorry, um, lovely listener.
Okay, so next question is, my son picks the skin on the sides of his fingers. He does not
Me
respond
too.
nor hear when he is finger picking. How do I interrupt him while he is doing it or after when he shows me all the blood? He cries as he is biting his skin because of all the
Hmm.
pain. How do I get his attention, or should I just keep letting him bite his fingers?
Probably not. What I would say is that's called a body focused repetitive behavior. I actually have that. I pick at my skin a lot. Um, and so I know it's going to sound like a plug, but our practice is one of the few where everybody who works for us is trained by the Trichotillomania Learning Center on how to treat body focused repetitive behaviors. So one of them is trichotillomania. That's a hair pulling disorder. I didn't have that. I just had bad genetics. Um, the excoriation. Thanks for the laugh. It's always good to have at least somebody in the audience laugh.
Took me a second, but I
Excoriation
got
is what right, excoriation is what this person's talking about. So excessive skin picking or biting that leads to bleeding and sometimes even infection. So at my worst, right, I sometimes have to put band-aids on my finger. So in answer to your question, really quickly with BFRBs, and I think we might have a presentation on that on the webinar series as well. If not, I'd be happy to do one. Um, but with BFRBs, we want to really understand the origins of what's making the person engage in the behavior. So for myself, if I'm sitting still for too long or I'm anxious, that behavior seems to increase. For others, it's more if their skin feels rough, they can't tolerate the sensation, so they'll have to pick at it to make the roughness go away, right? So it's helpful to understand the origins of why people do this. Now, it's not OCD, right? But it's very similar in presentation. So that's probably why a practice like mine that specializes in OCD also does BFRB work, right? So some of the interventions, you can call it to your son's attention in terms of the behavior, not in a scolding way, but more like, hey, here are some tools I want us to try using so that you don't hurt yourself, because I know you don't like it when you bleed. It probably hurts your fingers. My fingers get pretty sore around the edges when I do it too much. So they actually become kind of sensitive and I don't like how it feels, right? So we want to sort of tap into his or her motivation. Like, here's why we want to work on this, right? And then the next step is how do we work on it, right? So that's why it's really important to know what's behind it. If the person only does it in their bedroom, for example, we might say, okay, in your bedroom, maybe you need a fidget object, something to play with, right? Because maybe you do it when you're just idle and you have nothing to distract you and you're bored, right? So that's why I always have a baseball by my side. Like if I start picking, I don't want to like bite my fingers during a session with a client. So if I notice the urge, I'll just grab an object. And so when I hold this, it's a little bit harder for me to pick because I usually pick with these two fingers, right? But
Mhm.
if something's occupying my hand, it's harder to pick. Or I might put band-aids around the rough skin so that I can, if there's something blocking me from engaging in the picking behavior. Now, some people, they hate being blocked. It feels bad. It drives them crazy because their brain has a desire to pick at something. So for some of these folks, we might give them toys that like they can pick at, right? So I've had countless dolls who have been mutilated by children picking at the doll's skin or pulling out all their hair, but it gives them some sort of replacement behavior to maybe what their brain is craving. Um, or like popping those like little packing bubbles that you can pop, or breaking pieces of spaghetti if they like a snapping feeling. So we try and understand again, what are their needs and how can we address them? How can we block the behaviors? Never with shame, never with yelling or punishment, but more like, hey, this is not great for you. This doesn't feel so good. Let's use these techniques and we maybe even reward them, right? Hey, I walked past your bedroom and I saw you were sitting reading a book and you had band-aids on your fingers, or you were holding your baseball. That's a really great job. You get a sticker, and 5 stickers earns some sort of reward, right? So we want to reward using techniques that make them less likely to pick. So anyway, sorry if I turned this into a FRB presentation, but I really like that stuff too.
No, you're totally fine. I know that it is 8:30 right now, and some of you might need to hop off. If you can stay, and Rob, if it's okay, could I ask you a few more questions?
Yeah, sure.
Okay, beautiful. So if you do need to log off, I just wanted to remind you once again, thank you for attending, that there is an exit survey. Please take a moment to complete it, and that the webinar blog is now open and available for the next 7 days on the NJCTS website, which is www.njcts.org. And you will be receiving an archived recording of tonight's webinar. And in addition, that will also be posted to our website. So with that being said, the question, going to go back to a question earlier that said, what do you recommend about working through 12-step programs? For that, they meant like AA, Alcohol Anonymous.
Sure.
Programs with co-occurring OCD/morale scrupulosity, and like, would you focus on OCD first? Does that make a little bit more sense?
Yeah, I think a lot. Thank you for clarifying. So yeah, I can answer that because we've dealt with that many times over the years, right? If a person, so sometimes a person with OCD or any kind of major issue might be doing what we call self-medication, right? They drink or they drug as a way of dealing with their anxiety, right? And we would explain to our clients that that interferes with your ability to make progress via this therapy, because if the therapy is all about allowing yourself to feel your uncomfortable feelings, right, then anything that's aimed at suppressing it is counterproductive, right? So if the substance abuse issue was severe enough, I would definitely say, let's not move forward with this treatment. Not that I'm getting rid of you or abandoning you, but to say you need to sort of get the substance abuse under control for you to benefit from this therapy. Now, sometimes people will say, well, the reason I am drinking and drugging so much is because my OCD is so intense, right? But still, my preference would be for them to sort of, if we're talking like nightly blacking out, right, where they're actually in danger, I would want them to go to some sort of facility to detox, right? But let's say if it wasn't as severe, but it was interfering with therapy, if the client was just unable to stop on their own, then I would be willing to do a co-occurring therapy where I'll handle the OCD and somebody else who's a substance abuse therapist, or maybe having them go to AA and do a 12-step program would definitely be appropriate. So yeah, it's a great, really important question.
Okay, beautiful. So another question that we have is, I have a 6-year-old who has really been struggling with Tourette's and has multiple OCD issues, such as hand washing to the point of bleeding,
Yeah.
touching, organizing blocks a certain way, then his brother messes it up, causing major meltdown.
Yeah.
He has started a medication through a doctor that's located in Morristown, but I feel he needs more help. How can we get him into your practice for an evaluation?
Sure. And so what I would say is you can always go to our website, that's stressandanxiety.com, but we're not the only game in town. And my main interest, of course, is making sure that whoever needs help gets the help they need. One of the unfortunate things, because I want to be completely transparent, is um, there are, it's a lot harder to find a therapist who's willing to work with younger children. Full disclosure, I don't tend to. As a clinical director, I have a lot of responsibilities. I've got my own kid at home, so working with younger kids is a little too close to home for me lately. So I usually stick to 10 years old and above, and about half of my practice feel the same way, right? Younger kids come with their own distinct challenges, right? So one of the things that you might encounter is it's a little bit harder to find somebody who specializes in OCD that works with young children, and we consider somebody who sticks young. But we're not the only game in town, so one of the things I would definitely recommend is you can go to the International OCD Foundation's website. So that's iocdf.org. And on there, you can find lots of listings of different people who do the kind of therapy we do, right? So that's one route. There's also New Jersey. I'm a volunteer for and on the board of OCD New Jersey. So that website is ocdnj.org. You can find a listing of folks there who also, again, work with kids with OCD, right? So cast as wide a net as you can, because it's not always easy to find somebody, right? So typically my guess would be most 6-year-olds are going to have to come in after school or on the weekends. So those are hours that are harder to come by. So there's a good chance you might be on a waiting list. So cast a wide net, but get on waiting lists as soon as possible. Like I said, there's lots of good places. We're a really good practice. We're known for doing OCD work, but we're not the only ones. I've referred to other places as well if our waiting list happens to be too long. So yeah, but I think it's really great that you're looking for help, because these things can get really complicated. And so working with an expert who can, help get this under control earlier rather than later is really important.
Okay, and so we have two more questions.
Sure.
One of them is, my daughter has Tourette's and OCD. She
Right,
has many triggers, like certain words or sounds that make her tick. Can you
right,
provide any information on how ERP therapy is used for this and if it is successful?
right. Huh. That's interesting, because again, in OCD, our job is to antagonize the OCD, right? Let's activate those feelings, right? And then, not suppress, not do compulsions, right? Now, I'm trying to think of the name. I know with Tourette's, there used to be a treatment, masked something. I'm forgetting, like masked practices like that, right?
Mm.
But by and large, when I work with kids with Tourette's, I don't really try to antagonize the OCD unless we're practicing using competing responses, right? So maybe within session, I might sort of say, okay, what if there is something specific that might trigger the urge to engage in a tick behavior? Okay, we're going to sort of practice. What is our game plan for using what we call habit reversal training, or a competing response? So for those of you who don't know, a competing response is, let's say if a person's tick is to shrug their shoulders upwards like this, right? Right. The competing response would be, if they feel the urge to shrug their shoulders upward, it might be some kind of just sort of pulling your shoulders downwards like this, like I am right now. So if I felt the urge to do that, I might sort of do the opposite of that urge and hold that muscle in place, right? And so what we're really doing is we're training ourselves not to listen to the urge, and to do the opposite until that urge fades away. So conceivably, when if I'm working with a client, I could have them practice this, right? We're going to trigger the urge, right? It's coming. So let's say if it's a word, like if every time I say mustard, right, the person like starts flicking their shoulders, I might say, okay, ready? Mustard. And they're going to feel that urge, and I want them to just do this and hold it, right? So it sounds a little bit like exposure and response prevention. The only difference is, instead of just sitting there and allowing yourself to feel the uncomfortable feeling, we're going to train ourselves not to engage in the tick behavior. So that's a kind of, in a nutshell. I mean, it's a lot more complicated than that, but in a nutshell, that's how we might use a situation where we know there's a clear trigger.
Okay, and what would that would be pretty similar to CBIT, correct?
Totally CBT, yeah. So
Okay,
that's
that's
a
what I was
CBIT intervention.
thinking.
Yeah.
Yeah.
I was because I don't know how sophisticated the audience is, so I'm trying to stay away from like jargon. But
Yeah.
yeah, that's CBIT, which is Comprehensive Behavioral Intervention for Tics.
Okay, and no worries whatsoever. I know previously it was called habit reversal.
Habit
Okay,
reversal is basically a component within CBIT.
yes. Okay, and so our last question, Rob, and thank you so much for staying a little bit later to answer all of these. Our last question is, what is the name of the scale for OCD and how does one order it?
You can find a PDF for free pretty much anywhere. So if you, oh, did I freeze? Oh, okay, here we are. So if you go to Google, right, and you just type Y box. So for adults, Y-BOCS, and then PDF, you'll find it for free, right? And for the children, it's just Psy box, CY-BOCS, and then type literally PDF, you'll find it for free. It's not that's not hard to find. So yeah, they've been out for a long time. They have not only a checklist but a scoring sheet. I'd say leave the scoring to the experts, but the checklist, might be kind of pretty comprehensive in terms of, okay, these are different compulsions these are different obsessions people have, these are different compulsions people have, and it could be valuable for people to be able to look at. One of the things, because I tried to trim some of the fat off of the presentation, because like I always put too many slides, you might also want to Google family accommodation scale for those of you who have children with OCD. It's a really good questionnaire and again, you can find it for free, family accommodation scale. It's a good questionnaire that sort of asks you questions about like, what are the kinds of things that you do that might be enabling the OCD?
Okay, thank you so much, Rob. So
You're very
we're
welcome.
going to wrap that up for tonight, or wrap this up for tonight. Once again, thank you all so much for joining us tonight for our webinar on Obsessive Compulsive Disorder 101. There's an exit survey. Please take a moment to complete it. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered tonight, or any questions that you might have within the next couple of days. That website is www.njcts.org. Also, an archive recording of tonight's webinar will be posted to the site. And in addition, you will also, when we send our follow-up email, it's usually around 24 hours after the webinar, you will also have a link that has the recording as well. So our next presentation will be treatment approaches to help manage painful tics, which will be presented by Dr. Peter Morrison on Wednesday, November 16th at 7:30 p.m. Eastern Standard Time. This ends tonight's webinar. Thank you, Dr. Zambrano, for your presentation, and thank you everyone for attending. I hope you have a wonderful night.